Start the recording. All right, David, you should have control.
All right, this person has an interesting radiograph with this smooth bump here showing up. And I don't have a lateral at this time, but on a different exam, which doesn't on frontal view show it as well, you can still see our bump. And on lateral view, this is what the bump looks like, which I can't find. So absence of bump on lateral, but it's definitely there on frontal. So anybody have any ideas what this smooth bump might be?
Let me see.
Looks separate from the paraspinal line. Is it on the patient?
No, it's really inside. So the
Can you go back to the lateral?
Okay, laterals, this lateral, a different, slightly different era.
Something SVC or right atrium.
Okay.
Hold on, just go back to the other one again. It would seem to be a bit high for a pulmonary vein varix. Is there something where the inferior pulmonary veins are on the lateral? I couldn't tell.
So let's go back to Mr. Lateral. So the varix that I've usually seen on lateral is down here.
No, you can see it there.
Okay, let us proceed to cross-sectional imaging. And this person has a normal-looking size of pulmonary artery, although there is some degree of pulmonary hypertension on echo. And then has a large left atrium. And indeed, the bulge is caused by a pulmonary varix. So notice that the pulmonary veins are juicy in general. So here's the upper pulmonary vein on that side. Pulmonary veins are substantial on the other side too. I mean, not huge, but a little bigger than normal. And on coronal, we see indeed that it's this pulmonary varix that is the cause of this bump. Howard, you're right on. So very smooth walled lesion there. And this person's pulmonary hypertension is called type 2 or type 3. He doesn't really have identifiable lung disease here, and his left ventricular function was said to be normal on echo. He does not have mitral regurgitation, which is the usual setting for pulmonary varix. And he has just trace trace aortic insufficiency, and no real functional abnormality in the LV. Still, they're calling his pulmonary hypertension due to left heart disease, which is a little strange. So, and he does have a large left atrium on echo, so it's a big left atrium. So this is part of the generalized atrial enlargement. What are you saying, Howard?
Is it really a pulmonary vein varix, or is it just a funny bulge of the atrial wall rather than the veins so much?
Yeah, I think that's a good point. I think that it's general dilation. I mean, the veins are kind of fat, but it's not a distinct venous bulge. It seems to be the atrium itself. I think that's actually a better assessment. This is just part of his big left atrium. Yeah, I like that. It's really what gives rise to the vein, but it's more on the way to the vein than the vein itself. Good point. Okay, but kind of a cool thing on the chest radiograph. I would like to advance to the next case here. This is not cooperating. So let me do it this way. All right, this woman, I was asked to do diaphragm fluoro on her because she's very short of breath. And so when I did the fluoroscopy on her, I observed that she didn't move her diaphragm very much on either side. And I attributed that to really her hyperinflation. The fact is that her diaphragm, you know, when she takes in a deep breath, doesn't have much farther to go. So she doesn't exhale very much air, evidently. So, you know, her diaphragm motion is really secondary to her hyperinflation here. And her previous imaging had been unremarkable. There was some mild bronchial wall thickening on an earlier CT. And that shortly after her diaphragm fluoro, she went for our own CT. And it does show that she's got this generalized bronchial wall thickening and mild bronchiectasis is pretty much everywhere through the lungs. And this is the first study of this quality that she's had. And it does show that there's some mosaic attenuation. And here's our dilation. So the dilation and thickening of the wall of the bronchi is pretty generalized throughout both lungs. It's not sort of focally worse, or it's not accompanied by a lot of scarring that would suggest that there had been an infection, for instance, that set off this bronchial disease. And then the revealing thing is exhalation here, or expiration. You can see that she's got this profound degree of air trapping. She has more black lung, which is abnormal lung, trappy lung in this setting, than she has normal lung that can exhale and increase in density. And this comes up nicely on the MINIP version here in exhalation. You can see how much lung blackness she has here. All of this is air trappy lung. So lots of trappy lung, more than there is lung that can achieve some exhalation and turn gray. So the woman's history is long-standing rheumatoid arthritis. And complicating that is that about 3 years ago, she evidently had whooping cough. But I think the generalized bronchial disease that we see throughout her lungs, the dilation and the thickening of the bronchial walls, is fairly uniform throughout the lungs. And I think that really suggests a systemic problem, such as the constrictive bronchiolitis that can occur with rheumatoid arthritis, rather than post-infectious, for instance, post-pertussis, Swire-James syndrome as the cause of constrictive bronchiolitis. So the reason that her diaphragm fluoro was abnormal is because her lungs are permanently hyperinflated. She can't exhale very well, and that's why there wasn't very much excursion of the diaphragm. And then the cause of this constrictive bronchiolitis is probably her rheumatoid arthritis. That's what our pulmonologists consider. So she's a lung transplant candidate. She's being tried on some immune suppression with, I think, azathioprine or something like that, or cyclophosphamide, something that has been successful in some cases if you catch it early enough, of rheumatoid arthritis kind of constrictive bronchiolitis. But the exhalation views here, which we hadn't had before, I think really nail this diagnosis. Also accounts for the abnormality that I saw on diaphragm fluoro sniff test. Okay, so constrictive bronchiolitis attributed to RA in this case.
Yep.
David,
right, this is
was she, just a quick question, she hadn't been on like some of the old drugs like gold salts, and what was the other one they used to use a long time?
Penicillamine or
Yeah,
something?
thank you.
I'll check on the penicillamine, but she's not been on gold.
So, yeah.
So
Yeah, Jeff, that brings up a good question though, because we had a case a couple years ago where they had been on penicillamine and had rheumatoid arthritis. And I always just wonder if it's really the drug or if it's just the rheumatoid arthritis causing the constrictive bronchiolitis.
Right.
I'll check on her medications before I post the case. Good points. Okay, this woman came in after stroke. She's 37 years old. Normal, you know, the chest is the most boring part of her, really. Nice clear lungs, normal heart size, nasogastric tube in place, and indeed she has a hemorrhagic stroke here and a lot of surrounding edema and displacement of the ventricles. And then post-contrast, you can see there's actually active extravasation here within this blood clot here. So here's extravasated contrast on top of it. And then in her abdomen, she has some renal vein thrombosis here on the left. And I think this is maybe an ovarian vein or something going down. I don't think that's ureter going down, but that also has thrombus. And there were other mesenteric thrombi in this woman who died. So care to guess the context of what all of this is? I'm sorry, it's not really a chest case. This woman had been very reluctant to be vaccinated against COVID. She finally got the J&J shot. And then about a week later had these disastrous consequences. So this is a case of the hemorrhagic the thrombocytopenic thrombosis syndrome that goes with AstraZeneca, but also the Johnson & Johnson vaccination. So she had this devastating side effect of the vaccine.
Wow, I haven't heard about that in a while.
Right. In this case, this is a recent case. I think this was September. What were you saying, Howard?
No, sorry. Yeah, the thrombosis and thrombocytopenia and those complications.
Mm-hmm.
Autoimmune, immune-mediated.
Right.
Wow.
I mean, there's the risk of the same thing with the infection itself. So it's, you know, there are probably more cases of that than there are of the vaccine complications. Okay. And then let me show you this man who is, I think, in his 50s. This is an old radiograph from 2014 showing lowish lung volume here, but normal height of both hemidiaphragms. Then he had rotator cuff surgery on the right, and that was in 2019. And for that, they did a scalene nerve block. He noticed when he was in recovery that he was short of breath. And then he was sent home with a catheter in place so that he could deliver more pain relief to himself for several days. And he noticed that if he increased the amount of drip that was going in to dull the sensation there with the scalene nerve block, that he got more short of breath. So he backed off on that. And then the shortness of breath came back and it stayed with him. So he came in had a CT scan. This is an outside hospital. This was to rule out pulmonary embolism as a cause of shortness of breath. And you can see that his right hemidiaphragm is now elevated compared to the left. So this is, I think, about a week after his surgery. And if we look at cruised muscle thickness, we see that he's got good muscle thickness, but this is fairly soon after all of this, and it takes about a week to 10 days to see atrophy of the crus after somebody's had phrenic nerve injury. So he went for about a year and a half with shortness of breath. This did not come back, and we don't have a repeat CT to see how much thinning there was of the right crus. Then he read about this miraculous surgery that has been done on some people, and he was the 500th case to get this surgery. It was done in New Jersey, and what they do is they go in and they clear out the scar tissue around the phrenic nerve origins from these scalene nerve blocks. So he had this open surgery on his neck where they exposed all of the roots of the phrenic nerve, C3, C4, C5. They cleaned up the scar tissue. They said that his his phrenic nerve looked like a sausage with these constrictions in the thickened sausage. So they cleaned that up and they grafted sural nerve, and they took a nerve sheath, I guess from a cadaver or something like that. They did 3 nerve bypass sorts of things where they anastomosed the nerve around this scarred up region and stuff like that. And he felt better afterwards. He felt better. You know, they said that on the table, observing him fluoroscopically, his right hemidiaphragm recovered some. It went to a lower position, so he recovered some volume on that side, and he felt better right after the surgery. So let me show you sniff tests before and after. So this sniff test was done before he had this surgery. This is about probably a year into his difficulties with his breathing. So you can see that the right hemidiaphragm is pretty sluggish. The left hemidiaphragm moves briskly, and the right hemidiaphragm just passively follows. And then I think I have a sniff on here eventually. You'll see that he has got paradoxical motion. You can see there's a little bit of paradoxical motion with the sniff, but pretty sluggish right hemidiaphragm. And this is now after his surgery. This was done just a couple of weeks ago, and this is about a year out from his surgery now. So you can see that he's recovered a lot of function of that right hemidiaphragm. And so he's got about probably 70% of his function back, at least half. So a remarkable result. Now, this is not your ordinary phrenic nerve kind of problem. So the most common phrenic nerve injury we see from surgery is when they do heart surgery. So it's way down here. And his surgery was, his difficulties were all in his neck, which is easily exposed. So I'm not sure that that kind of surgery has much to do with phrenic nerve injury at this point, where the phrenic nerve drapes around the heart. So it's not as if you can operate on everybody who has a phrenic nerve problem and restore function like this. But this was a very good result. So they had cookies made for him that said 500 on them because the clinic was so pleased with having achieved that number of cases. And they have published some of their results. It shows you that you can solve some phrenic nerve problems. It's not clear to me how much is just the removal of scar tissue and how much is the bypass surgery where they graft in pieces of nerve to go around the damaged area. I'm not sure whether that's part of it, and I haven't read their studies in detail to determine how many cases with or without the nerve transplants were successful or not. Okay, so there's some hope for some people with phrenic nerve injuries from a surgical approach. Those are my cases.
All right, thanks, David. Okie dokie. Who'd like to go next?
I can go anytime, Jeff.
All right. Make you the presenter.
Okay, today I want to show two cases in which, particularly for trainees, this should be instructive. And they both have to do with vessels in part. So here is a person, this radiograph back in 2019 was described as normal. And giving you a moment to look at that, I hope that folks can appreciate that the pulmonary vessels are not normal, they are distended. And the vessels that are distended are the pulmonary arteries. And the question is whether, in addition to the pulmonary arteries up here, and of course that can be hard, we also have distended pulmonary veins. So for those of you that teach the notion of a bronchoarterial ratio, here's the bronchus, here's the artery, anterior segment, that ratio is increased. And if you look at the vessels in the lungs, They are distended, but they're distended everywhere. And this is the pattern that Eric Milne described as a balanced distribution of pulmonary blood flow. Let me bring up this radiograph. So the time between these is that period of time, about 2 years or so. And notice that the pulmonary vessels are still distended. Indeed, in addition to that, one would wonder whether the right atrium and perhaps thinking ahead, the right ventricle are larger than they were in 2019. So if you see this and you believe that we have distended arteries and distended veins in a balanced distribution of pulmonary blood flow, one should think of a left to right shunt. So let me now bring in this. So this I made from a CT, of course. So this is July, this is the radiograph from November. And appreciate that we have distended vessels. And in starting to look at that, if you see two vessels parallel to each other up here, typically the artery is medial, the vein is more lateral, but of course there's a lot of overlap and that isn't always easy to perceive by any means. But as we scroll through this, bingo, at least on the CT, of course I'm thinking ahead, we see a distended vein here, rather distended, and there it goes towards the SVC right there. So we are beginning to be able to diagnose PAPVR involving the right upper lobe, and of course the association between that and sinus venosus-type ASD. He had a workup. His MRI showed a QP to QS ratio of 3.2, a substantial shunt. I wish I had a CT to show you that was with cardiac gating, because I really can't easily diagnose the presence of what I believe is a superior sinus venosus ASD up here. If you actually see it, let me know. But that's the diagnosis. That's the diagnosis we have right now.
Right there. Keep coming down a little. Keep coming down, because it's yeah, and you'll see the communications like right in there between the atrium, or between the SVC and the / right atrium and the left atrium, right where that pulmonary vein's coming in.
Yeah.
And even a little bit lower. Yeah, well, yeah, that's too low. Yeah, but you can see it right there.
Yeah, like right in here. Yeah.
Yeah, and that's always important, because I think we've all seen cases of this missed on transthoracic echo, just because it's the furthest away from their probe. If they're doing a 4-chamber view, or some from the outside, that's hard for them to see on echo.
Yeah. Good. It's a very interesting case of, and a very nice demonstration of, so-called balanced distribution of pulmonary blood flow, left to right shunt, and the patient's going to cardiology. This one is a different kind of case, but I'm going to show you, not the order in which everything was done, but I want to show you this, and I'm going to try and make this a little bit bigger. This, as a perceptual challenge, is much harder, but particularly for trainees, when you're looking at the pulmonary vessels, look for symmetry. Look at left lung compared to right lung. Look at upper lung zone compared to lower lung zone. And I'll give you a moment to look at that. Now, this is really subtle, so this is definitely a hard one. But let me bring alongside this, which is what I made from the CT. So now when we have this for comparison, I hope that you can appreciate that, and I'm going to take that away, that the pulmonary vessels up here are small. They are small compared to the other side. And of course, it's easier to perceive when you have that image. And much harder is to perceive that the pulmonary vessels in the right lower lung down here are small too, compared to the left side. So small up here and small down there. If you have a patient with pulmonary hypertension and you see this kind of thing, then think of course, vascular pathology. And here we go. So no surprise, for example. Again, I'm not showing you this in order, but I'll just show you the important parts. That we are going to see that when you do a ventilation perfusion scan and SPECT, no surprise that really relatively little goes up here and almost nothing goes down there. And now, of course, I'm going to show you the counterpart for what we see here, which is really no artery going to the upper lobe right there. And look at the extent of abnormality down here, where we have substantial abnormality that goes along with what we see there. And then we have the bronchial arteries. So a dramatic case of CTEPH that you see there. Now I'm going to go back in time to, I want to see if I can get my time right here, 2020. And here's a CT from then. And you can see the clots in the vessels. Already we have bronchial arteries even back then. So we have that diagnosis. And then what I want to show you last of all is a comparison between before and after. So I need to get my timing right here. Before and after surgical thromboendarterectomy. So here we have, let me go back to before, if I can get my timing right here. There in April, and look how nicely the surgeon was able to do an endarterectomy to restore blood flow to the right lower lobe. And let's go to the left upper lobe. Get my timing right. Okay, this is the most recent one, sorry, right here. And comparing this guy with right up in here. So really nice, large morphologic result from the surgical endarterectomy is what the most recent one shows down here. So kind of a nice case overall. Again, analyzing the pulmonary vessels and nice findings of CTEPH treated surgically. Okay, I want to show you this really interesting case here. So I came across this case after the patient had gone to a surgical lung biopsy for ILD and a chronic respiratory illness. So I'm going to show you things a little bit out of order, but let's just start with the radiograph here. Really nothing much to see on that radiograph, but I want to show you, and this CT was read as basically negative. And I'll scroll through here. I'll say the big findings, let me actually start down here, which are very much akin to the case that David showed, are the bronchial dilatation, the bronchial wall thickening involving bronchi, and then perhaps to some extent there's some secretions or something in the lumens of the smaller airways, but these findings are definitely abnormal. Now, I'm going to bring alongside this some expiration series, which is that. Let me actually take the one right at the bottom. And this is important because if you look at this and you're looking for a very obvious mosaic attenuation appearance, where the areas of relatively low and high attenuation really stand out, you don't see that there. And let me show you another image, expiration from the lower chest, But the important observation to make here is that if you make the assumption that the patient has breathed out, this is a substantive abnormality. So typically when you have a patient and they say to the patient for the expiration series, take a breath in, breathe out, hold your breath, press the button to obtain the scan, the time between the exhalation instruction and taking the scan is short. And that's a problem because it can lead to misinterpretation of what we're seeing over here. So let me show you this. And this person has got substantial expiratory airflow obstruction. And I want to show you this, but let me just try to make that black and white. Okay, like this. So if you look at this here, this is a normal curve looking at volume and time. And you can see for this patient, and we're going in seconds here, all the way out to 6, 7, almost not even plateauing like you expect here. So if you press the button to scan the patient and give the patient, say, 3 seconds or so to exhalation, you're not going to get any emptying of that lung. It makes kind of sense because this is very severe airway obstruction. So this tells a story as well, and you really have to be aware of that to diagnose properly substantial findings of air trapping.
But Howard,
Yep.
I would make the point that the vascular abnormality in your case here is pretty profound in that right lower lobe. There just aren't any vessels out there at the periphery. Using symmetry, as you pointed out before, there's a paucity of vessels out there. So that's, that is also profoundly abnormal in this case and goes with a lot of vascular change caused by the ventilatory problem. I mean, it's really just, there are no vessels out at the periphery in that right lung base.
So relative hypoxia and hypoxic vasoconstriction. Yeah, that
Right.
too. Yeah.
I think the vascular stuff is profound in this case. It was visible on the chest radiograph.
Agreed. And Howard, even on the inspiratory, if you narrow the window, you can see there's very little normal lung there. Like you're saying, that on even tighter window than that, you'll be able to tease out a difference.
I think the part of the problem here in perceiving all of this is that it's so bad on both sides.
Yeah.
You're not aware of much difference. If somebody doesn't move any air and the lung stays black on both sides, it starts to look normal. But the paucity of vessels is still abnormalities, despite the more uniform blackness.
Yeah, exactly. So there are a number of subtle observations, but one has to interpret this in context as well. I'm in a patient with severe obstructive airways disease, that this is constrictive bronchiolitis of substantial severity. And then just to complete the case, I'll make this big. Here are annotated images from the open lung biopsy. So I'll just go to, in the interest of time, images that show the pathology best. Here is a bronchovascular bundle, airway, and companion artery. The distance between here and out here, or the pink stuff, is substantially increased. Let me show you this to better advantage here. So here we have respiratory epithelium. Right here we have the relatively slender nuclei, just there and there, of smooth muscle. The distance between here and there is substantially increased. So the amount of subepithelial tissue, and I wish I had the trichrome stain to show you. I don't know what happened to that, but with the trichrome stain, the distance between here and here was filled with blue. So this is a tremendous amount of subepithelial fibrosis in the wall of the airway, typical of constrictive bronchiolitis. Here's the same kind of thing, even more severe for constrictive bronchiolitis. So a very dramatic case. So yeah, very interesting findings. To the uninitiated, you can go right by these findings when it's this severe and diffuse. But one really has to have the history. You know what you're looking for, and you have to look for the findings that go along with substantial air trapping, and watch out for analyzing the expiration series.
Very nice case. Thanks, Howard.
Do we have a diagnosis, Howard, of the ILD? What did they?
Not the cause of it, David. Not the cause of it. Not the potential.
Yeah, the biopsy will rarely, if ever, show you the cause. Okay. Is that it, Howard?
Yep.
Thank you. All right, let's see. Peter or Travis?
I can show two really quick.
All right.
Some interesting ones this week. Let me make sure I've got, all right. There we go. All right, you see a radiograph here?
Yep.
So this is credit to Paige McAdams, because I have never made this observation or even thought about this as being diagnosable on a radiograph. And this is from the other day. And so this is, I don't know what this type of PICC is. It's a little bit smaller caliber than what we typically see. But you know, Paige noticed that it had this kind of little bit of a tortuous route there. And I can show you a CT from just a couple of weeks ago, and you'll see that, you know, it is in the superior vena cava. But I'm curious if anybody has ever used like that kind of, you know, corkscrew path or circuitous path to make a diagnosis related to the PICC. Because here you can see it's a nice smooth path on the prior CT.
No.
Mm-mm.
No.
So Paige told, you know, he made the observation that he thought that this is often suggestive of thrombus of the vein surrounding the PICC. And he's seen this before a couple times in the remote past, and it turns out he was right in this case too. And I thought he was crazy, but this guy had come in with 3 days of worsening upper extremity pain and chest pain and inability to raise his left shoulder. And they subsequently did an ultrasound here, and I had key images, but I guess they're gone, but I can quickly go through it. You can see there's the catheter, and there's a little bit of increased echogenicity surrounding it. There's very little flow surrounding it. And then there is a compression image when they do it right here, and you can see with compression of the axillary and the subclavian vein, there was no compression of it. So thrombophlebitis surrounding a PICC diagnosed on the chest radiograph.
So Travis, is his thought that the fact that it's sort of wavy like that is because it's adherent or fixed versus
Yeah, exactly.
the normal flow, it should kind of float to where it's like
Yeah.
under normal tension?
Yeah, I don't know. I wish we had a CT in this case, but I have never even thought about that as a diagnosis before that you can make on a radiograph, but he was right.
That's awesome.
So what do you think this thrombosis was attributed to? Was it a lot of exercise or something like that, or?
No, so this guy he's had a prior renal transplant. He had the PICC placed 2 weeks ago, or 2 weeks prior to this incident, for just at-home ganciclovir for CMV colitis. So, and he has underlying lupus was the cause of his nephropathy and his renal transplant. So he's probably still coagulopathic, would be my guess. So that's the theory. All right, and then this radiograph is kind of fun and ties together a lot of observations that have been made throughout this hour, both Howard and David. And in this case, you can see that there's asymmetric enlargement of the left hilum. Notice that there's a relative paucity of vessels throughout the left lung, and leading to the left lung looking more lucent. Here's the CT, and I'm actually, well, I'll show this original CT. It's unfortunate that people still do 5mm slice thickness images. But you'll see the cause of this. I can start on lung windows just so you see that this corresponds to just an overinflated left lung, and as a result of obstruction of the left main stem bronchus, and we'll get to that in a moment. And I think also just relative hypoxemic vasoconstriction as a result. So you can see that there's this soft tissue that is infiltrating and extending from kind of the subcarinal space left main stem bronchus out along the airways in the left lung. And even, I'll show you a more recent study here, but you can see it's extending along the airways. And I think a clue to the diagnosis here, I'm withholding a piece of information or a piece of history that's key, but a clue to the diagnosis is the presence of this abnormality as well. Does anybody want to take a guess of what this entity is and what this patient's underlying diagnosis is?
Was that? I mean, that looks like. Is that?
I'll show a more recent image, and you can see this thing is still there. It's not a vein, and then this process has actually progressed, and you can see this is a much nicer quality study, and you can see how all of this stuff is just infiltrating out along the entirety of the bronchovascular tree, and even creeping down into the, David, would this be intersublobar septum down here?
Yes.
Yeah.
Okay, so any skin lesions on this person?
You're getting warm. What do you think?
I'm wondering about Kaposi sarcoma.
Oh, well, this has been going on for a couple years, and she does have a skin, there are skin lesions with this disease. It's not HIV and Kaposi sarcoma.
Okay.
And the hint is that we see this sometimes, that this is a neurofibroma.
Oh.
Probably, I would guess this is of her vagus nerve. And this is all a big plexiform neurofibroma involving her tracheobronchial tree. And that's been proven on multiple biopsies when they've tried to debride this thing. And so she has NF type 1.
That's crazy.
Oh my word.
So,
I don't think I've ever seen one grow in this pattern before.
I haven't either. I've seen, I think we've all seen like large retroperitoneal ones, or ones that just grow at the root of the mesentery along vessels. Certainly they're subcutaneous as well, but this is a plexiform neurofibroma.
I was trying to make that into a vein there and trying to figure out. Oh, wow. So it's interesting because the vasculature looks fairly intact. I mean,
yeah, I would agree with that.
I mean, the superior vein squeezed. I mean, they're squeezed a little bit, but
yeah.
So it must be fairly soft, and that's why it's able to infiltrate like that. I would think of neurofibromas as like firm and rubbery, but
it's almost like the tissue is growing in the connective tissue sheath of the bronchoarterial bundles and just growing down the sheaths.
Well, and that's what plexiform neurofibromas do. They just kind of grow along, wherever you have nerves. So, but I thought this was quite the case.
Oh my word.
All right, Jeff, I'll stop there.
I think we just have to stop after that one. All right, Peter, do you have any cases this week? And welcome back, by the way.
Yeah, I got a few. Hey, can you guys hear me?
Yep, I'm clear.
Okay, so I showed this case a few weeks ago, and I have some follow-up pathology.
Okay, perfect.
So patient with HIV, and this looks like this was a presumed Kaposi sarcoma, just extensive thickening along the bronchovascular bundles.
Oh, yeah.
And here's the path. I thought it was just nice pathology. We just finally got it back. So here's the here's a slide. This is a cross section of the airway here and here, bronchioles, and this is a a long axis view of a bronchial, and you can just see this extensive. These are spindle cells, all these nuclei here, spindle cell tumor that's infiltrating along the interstitium, and then some collagen deposition. And then here's a magnified view. So you have the spindle cells here along the encasing the airways, and some collagen, and then this is a HHV stain, so herpes 8 virus, and the brown is the positive stain.
So it's a nuclear stain. Wow.
Yep, nuclear stain, yep, for HHV8. Yep. So it's Kaposi sarcoma on path.
Wow. Yeah.
This one is an interesting case shared to me by one of my MSK colleagues. So they're reading this pelvis, or lower extremity and pelvis. And you can see this abnormality here, the femur. So they were worried about I think this patient already had a diagnosis of, so it wasn't diagnosed in the scan, but it was just a very impressive hypertrophic osteoarthropathy case. This patient has a diagnosis of lung cancer. So this is one of the more impressive ones I've seen of that, and you can actually even see it on the they included part of the forearm here. You can see it a little bit on there too.
Was it a small cell or a non-small cell?
Yeah, it was a adenocarcinoma.
Oh, okay.
So here's the mass.
Yeah, I haven't seen that in so long. I mean, you hear about it in training, but in reality, I mean, I think I haven't seen a case since that we've seen a previous one in this webinar.
And then they told me that sometimes they think they see it, and then the patient ends up having doesn't end up having lung cancer. So sometimes it turns out to be a false positive.
Oh, okay.
This one was a kind of an interesting case. So here's this was a new airspace opacity in this patient, and you kind of can see the low density or low attenuation here, right? So I thought this was going to be, I like this for a lipoid pneumonia, and that's what I called it. But I said, just to be sure, I said consider getting a transbronchial biopsy, and so I'm glad I did that, because it ended up being a combination of lung adenocarcinoma. So this is acinar and papillary pattern of adenocarcinoma, and and lipoid pneumonia as well. So this is the slide showing the lipoid pneumonia. You can see the lipid droplets here, and then this is the adenocarcinoma.
Oh, that's really odd. The concurrent presence of those two things.
Yeah.
That
maybe it's a lipid producing adenocarcinoma.
Wow.
Yeah.
That is.
So the lesson I learned from this is not to be too overconfident. So.
Yeah, I'm glad you had a little bit of a suspicion there, because also you don't see the surrounding ground glass and even crazy paving like we often see with lipoid pneumonia, because I think of it as more of a ill-defined thing.
Yeah.
Yeah. The sense I get from this is there's some kind of post-obstructive process here also with some volume loss. So that's why I wasn't super confident.
Yeah, I wonder if that was the cause, because you can, if I remember correctly, you can get like a post-obstructive lipoid pneumonia because of surfactant breakdown products.
Yeah.
I don't know if the pathologist is able to tell or can comment on that when they sign these out, but it makes you wonder because, like Travis was saying, all the lipoid pneumonias I've seen have been very stellate, spiculate. I mean, very ugly looking.
Yeah. Yeah. And this is pretty well circumscribed. Yeah. So this could just be post-obstructive. Yeah.
Oh, that's a great case and a good reminder.
This is just a quick one, good for trainees. We had, let's see which one was the first one here. Yeah, so this one.
Yeah. Okay.
So there's a filling defect, apparent filling defect in the right lower lobe. So this is just a good example of smoke artifact.
Great. Yeah.
And just I guess they didn't believe us, so they got a follow-up PE study the following day. And the artifact is largely gone. But you get full flow and you get incomplete mixing of contrast here in parts of the lung where there's so much fibrosis.
If you put a cursor on that, what kind of values do we get on that first scan? If you just get some
What
point
kind of Hounsfield units?
Hounsfield units, yeah. If you just hit tab, and we'll see the Hounsfield units and
Okay.
like a mediastinal window. I'm trying to see, it's too small, but let's see.
Yeah, you could see when you put it on just regular soft tissue windows that it's going to be pretty high.
Yeah,
Just at a standard 40-400 or whatever.
Yeah. And you
Yeah.
can kind of see a gradient.
Yeah.
As you,
it's not uniform.
yeah, not well
Right.
defined.
Yeah.
Yeah, very nice example.
Gradient. And then, yeah, I mean the biggest giveaway is how much fibrosis there is down there. So this, by the way, was somebody that was diagnosed as IPF at the outside hospital and sent for transplant. But I think we got it. This doesn't look like IPF, and they had a positive they were positive on the autoimmune panel. But this was from a few weeks ago, and I don't remember what the lab was exactly. But it looks like an NSIP
Absolutely.
Yep.
pattern.
Yeah.
This is a patient who, she's 34, and she was sick for like she was just feeling not well for about 2 years, shortness of breath. They diagnosed her with asthma, and then she eventually got COVID. She was treated for COVID. She had airspace spastities bilaterally. She was positive for COVID. She was treated for that, but then she never really, the airspace spastities never went away. So, so then she eventually got a biopsy, and this is, as you would expect, this is not COVID. This is.
Was she coughing out adenocarcinoma cells?
Bronchiolitis.
Lots of
No.
mucin.
Yeah, you would expect that, but yeah, I'm not sure. I didn't see
Wow.
that. Yeah, so this is
And I think
34 lung ad. No, I think no smoking. No, this patient did have she had about a 10-pack year history of smoking. But you can see, especially this area right here, is what kind of COVID never has these kind of acinar pattern.
exactly
nice,
those nodules, right? Those discrete nodules in the upper lobe that should really. When I see those, I always get nervous about adenocarcinomas.
Yeah.
And look how low attenuation even the background ground glass is.
It's also got nice crazy paving, so it must really be alveolar.
Yep. Very nice. Great
Go to
pattern
soft
here.
tissue windows for a second. Yeah, look at that. It's almost like fat attenuation in there.
Yeah.
Cool.
Wow. Well,
And then one more quick one. This one is just a. And I think we froze for a second.
So in a way, that's another case of fat associated with adenocarcinoma, like your first case,
Mm-hmm.
or your third case? So
Oh, that
maybe
one was that one was
adenocarcinoma, leaves behind fat.
yeah, and then this last one I forgot to mention is a mucinous adenocarcinoma, the most recent one that I just showed. This one is a eye test. If anybody can point out a mediastinal mass here, I found this one in retrospect.
Left apex.
Left apex.
Left apex is something.
Right here.
And there's asymmetry of the lung density for whatever reason.
And that rib, that second rib looks a little, or third rib looks a little notched on the left, or it's maybe just deformity. And then there's the deformity of the fourth and fifth rib below it.
Neurofibromatosis, guys?
Yeah, very.
That's what I was thinking.
Very close, but it's posterior mediastinal.
Little schwannoma or something.
Yeah, exactly. It's not. Yeah,
Oh, that's
the actual. Yeah, so
Good one.
Is it a lateral? Can you see it? It's probably too high. I was wondering if you could see the wide neuroforamen on the lateral. I'm guessing it's obscured by.
I don't remember. You can't see it on. I mean, maybe you can make out something here, but I thought it was just a really subtle thing right over the clavicle here.
But this person doesn't have other manifestations of neurofibromatosis. This is just an isolated neural tumor.
It was just a schwannoma. They biopsied that schwannoma. Came back schwannoma, as you would expect.
About the they're inpatient. So
I think I went through all mine. That's it.
All right. Well, I have another call that starts at 3, so we'll end it now. We just have 2 minutes left, but I'll show mine next week.
Yeah.
But those were great cases today.
Thanks, guys.